Welcome to our webinar series on data and measurement in youth mental health. Before I introduce myself further, I want to make a note about the translation options available. Unfortunately, we don't have live voice translation, but you can access translation in French captions if you just go to the bottom of the screen and select the three dots that are on the right, and then you can select captions and then translations. If you have any issues, please let me know. Please feel free to ask your questions in English or French, or to write in the chat in either English or French. I'm Alyssa Frampton, and I'm the coordinator of the CIHR Catalyst Grant in Youth Mental Health. It's part of a pan-Canadian networking and knowledge translation grant aiming to provide opportunities for the youth mental health community across Canada. And through this particular webinar series, but globally as well, we're looking to engage, network, share developments, and build collaborations around data and measurement. Also through this webinar series, we're really hoping to better understand the current and future landscape around data and measurement in youth mental health, what's happening, where the gaps are, how innovations are filling them, and how we can all move forward together. So far our series has touched on why data and measurement matters, the basics of what it means to have a learning health system, responsible measurement, considering personalization and standardization, and the things we might want to consider about standardization in data collection. We also just heard before the summer break that we just took from Dr. Ann John around big data and youth mental health. And you can find any of the past webinars for our series on our YouTube page, and I can add that to the chat in a moment. And lastly, before I introduce you to our wonderful speaker for today, we really welcome you to add your questions into either the Q&A part or into the chat function as the presentation's happening. We'll have a designated time at the end for Q&A. If you'd like to save your question until the end, you're welcome to do so. And I will go ahead and introduce our speaker. So this is the 7th webinar of our series, and we're really lucky to hear from Dr. Suzie Lavoie on harmonization and data capture in youth mental health research, learnings, and challenges. Associate Professor Suzie Lavoie is the Research Data Strategy Lead at Origin and the Centre for Youth Mental Health at the University of Melbourne, Australia. Her work on data governance consists in ensuring that the research data collected by Origin researchers follows the FAIR principles and getting this data ready for reuse by the scientific community. She has led a project on the harmonization of research data capture and is now involved in Australian-wide initiatives on the facilitation of data sharing. So I'm going to pass it over to Dr. Suzie Lavoie, and we will get started. Thank you so much for joining us.
Thanks a lot, Alyssa. Thanks for the introduction. Thanks everyone for being here, and thanks to Jay as well for the opportunity to present in this series. I've been watching them on YouTube and really enjoying the various presentations. I'm not watching them live because that would be in the middle of the night for me. All right, so let's not wait any longer, and let me share my screen. Alyssa has already mentioned what I'm going to talk about today, and I will talk a little bit more about who I am and why am I here talking to you, what are my credentials. Just in a moment. Before that, I'd like to acknowledge the traditional owners or custodians of the lands on which we all are today. I'm on the land of the Wurundjeri people of the Kulin Nation, that's in Naarm, or better known as Melbourne in Australia. But I was born and raised on the land of the Huron-Wendat people. That's where the river narrows in Quebec City. So I lived all my childhood and youth back in Quebec and Montreal. Then let me finish my acknowledgement here. I want to make sure that I pay my respect to elders past, present, and emerging, both here in Australia and in Canada as well. So yes, I came from Quebec, and then at some point I decided that I wanted to try something new after my undergrads at the Circadian Rhythm Laboratory in Montreal. I went all the way to Switzerland, where I did my PhD in schizophrenia. So Switzerland is a really beautiful city. I was very, very grateful to have the opportunity to live and study there for 7 years. I did my first postdoc there as well. So the university is beautifully located just at the shore of the lake, and at the other side of the lake there, you can see the Mont Blanc. So it's really, really beautiful. But of course, the psychiatric hospital is not near the lake. It's all the way up the hill, and it's not as pretty as the university. But we did really good quality research there. And I went back last year, and they have put this building down, and they now have a beautiful, shiny new building. So after doing my PhD in Lausanne, I was ready for new challenges. So I traveled all the way to beautiful Melbourne in Australia, one of the most livable city on earth. And this is where I've been working for the past 15 years. So at Origin, we are leading in youth mental health research. We provide care, and we advocate for young people who are aged between 12 and 25 years. So we have a research team which is quite large. We do research in most of the various domains of mental health. We have a few clinical teams. A few of them are specialist programs, so they provide acute care to young people who are quite unwell, but we also provide tertiary care in what we call headspace centers. So we have the two types of clinics under the Origin umbrella. We also have a policy team and a knowledge translation team to ensure that all the research we do is then translated into the community and to advocate to governments. We have an Origin digital team that does treatment via apps or VR related kind of treatment or interventions. And we have an Origin global team, which ensure all the international relationships. So the project I'm going to talk to you today, about, is a project that's very dear to me. It started in 2014, so that's a long time ago. I was I was invited to lead the project with a broader goal to improve Origin's data sharing capabilities. So back then I was taking a turn in my career. I was trying to leave the research focused kind of career to do a bit more of research operations. And this kind of project was really appealing to me. So I agreed to work on that harmonization project. So imagine a world where data sets coming from different research teams around the world could be pulled into a large data set without any compatibility problem. That would be absolutely amazing. And creating these data sets would be great for many reasons. But before I talk more about the harmonization of data collection, I'll try to convince you that large data sets are great. So there's several advantages to large data sets. One is that it, of course, increases the representation of the population that a researcher would want to study. It improves the accuracy of machine learning models, for example. So if we provide the model with more data for training, then it can learn patterns and relationships more effectively. And this leads to better prediction and to more acute generalization of the results. Large data set can also help make models more robust to noise and outliers. So models can learn to ignore irrelevant and misleading information. Large data set enable the detection of rare events, which can be needed in the identification of subtle differences between disorders. So I'm pausing a second here to remind everyone that it's 6 a.m. here. I'm still sipping on my first coffee, so the words don't come out real right just now. It's gonna come. Finally, researchers can uncover new insights, patterns, and trends by exploring large data sets. For example, if they obtain data set from various countries, they could look at geographical differences, for example. If they obtain data from origin, where we do youth mental health, and from another institute where they do adult, where they see adult populations, we could look at age difference between the various data sets. So with large data sets, researchers can address questions that would not be answerable with more traditional methodology. And researchers don't need to collect new data. And that's really important. That means no new grant application, no new participants needed to be recruited, and all the staff that need to be hired. These staff can rather work on the use of secondary data. But there's several challenges associated with the build of large data sets. First, well, typically these large data sets will be built using data sets coming from various research centers. And this can lead to ethical considerations, because when these data were collected, maybe proper consent was not obtained from participants. And some people have also raised some privacy issues that can be related to the sharing of identifying that data. There's also several computational considerations, because large data set will involve big computational power. Also, large storage space is needed. Typically, researchers base their research aims and hypotheses on the literature. So they try to find gaps in knowledge, and they build their research to address these gaps. Now, with data-driven approach that we can follow when we use large data sets, this kind of approach may limit the interpretation of the results. There's probably more challenges than the ones that are listed here. And the goal of the project that I want to talk about today were not to address all of these challenges. What we wanted to address is the fourth one here, the compatibility of the data sets. So I'm coming back to this illustration that I presented before. If we want to take all these data sets coming from different centers and put them in one large data set, there are automated ways to prepare these data sets for addition into large data sets, but this preparation would include renaming variables, aligning categorical values, treating missing values. So it becomes lengthy, and it can become expensive as well. And it can also lead to the introduction of error in the data. So to avoid the need for data preparation, we thought, okay, why not make sure that every researchers collect the same data the same way? Wouldn't that be fantastic? We quickly reduced our expectations and ideas of grandeur, and we limited the project to youth mental health in Australia. So the aim of our project was to harmonize the collection of data across research centers in the field of youth mental health in Australia. So what that would mean is that all the researchers involved in the project would use the same core set of measures. They would record the data the same way. And so once the data are collected, they can easily be pulled into these large data sets. So we created the Neurobiology in Youth Mental Health Partnership, and we invited researchers and clinicians from 13 institutions across 4 of the 8 states and territories in Australia, namely New South Wales, where Sydney is, Queensland, where Brisbane is, WA or Western Australia, that is Perth, and of course Victoria, that's where Melbourne is. So our methodology was, so what we were trying to do in this first phase was to determine what are the measures that we should use as core measurement. So these are a few criteria that we submitted to our panels. So we thought that if we wanted to be able to use large data sets to better understand the neurobiological changes that occur in young people as they start experiencing mental health challenges, we thought that a transdiagnostic approach was the most appropriate. So we have opted for a research domain criteria approach, which integrates different levels of the information collected from research participants, all the way from the molecular level to the clinical presentation of the person. We created 4 panels in these 4 domains, so clinical assessment, neurocognitive assessment, neuroimaging, and biospecimens. And we asked the panel members to answer that question. If you had 30 minutes with a research participant, what assessment would you conduct? Always keeping in mind that we're talking about youth mental health. So it took our panelists 2 years to come to a consensus. They met in person, via teleconference, via email, and 2 years is a long time. And I will come back to that when we talk about the lessons learned from the project. Other criteria that we adopted to make sure that we gave some sort of frame to the project was that the measures had to be applicable across diagnosis. They had to be relevant to young people aged 12 to 25. Cost had to be considered, especially for self-report measures, for example. We also wanted these measures to be accessible in the public domain. So we started, remember how I said that we started this project in 2014 and the paper came out in 2020. So when you involve a lot of researchers and clinicians in a project, there's a lot of discrepancy in priorities for every person, and we really wanted to be robust in the choice of our measures. So it took the time that it took, but but the project was really great to run, and I'm gonna take you through some of the results. So these people that were co-authors on this paper, they all took the lead in one of the panels. So these are the measures that were selected for the primary clinical assessment. It takes between 30 to 50 minutes to complete. So it's longer than the targeted 30 minutes that we have. But it was agreed that these self-report measures could be done at home if that's what participants preferred. And they're measures of depression, mania, suicidal ideation, and more. They're the main domains of, mental health, clinical care. And the idea with this primary battery of measure was to get a snapshot of the person as they present at the clinic. The panel also wanted to see measures of OCD, PTSD, ADHD, autism, and more, but the battery was already too long, so they decided in the paper to suggest a secondary battery of measure for people who may be interested in these domains as well. Then we have the results for the other three panels. So on the left-hand side is the results for the neurocognitive domain. So these measures were mainly taken from an available battery of measures that's called Cogstate. And they measure they give a good snapshot of the neurocognitive state of a person as they enter the clinic. As for the biospecimens, it was suggested to do a blood test and to measure some of the biomarkers that are presented here. As a secondary biospecimen collection, we suggested to collect hair sample for stress measurement, cortisol stress measurement. And finally, there were also suggestions that were made for brain imaging modalities. Okay, so now that we have a nice, shiny set of measures that we call the harmonized protocol, what do we do with it? So the next step was to invite researchers to start using this battery of measures with the view that if they contribute the data they collect towards the large data set, they can also use that data set. So it's a win-win situation there. But when we started to invite people to use the harmonized protocol, this is where we started to face the limitations of the project. So we started by offering the battery to a few origin researchers, and it was adopted by a few of them, and that was great win. They could see the value in collecting the data in a harmonized way. It was in the grant application for the Prescient project. So for those of you who have not heard of the Prescient project, it is one of the two networks that are part of AMP Schizophrenia, which is a huge project that's funded by the American NIH. The other network is called ProNet. And so there are sites all over the world. There are a few in Canada as well. And so it is a huge project. And when Prescient was submitted to the NIH, initially, it included the harmonized battery. So that was, it was great to have it in there because we knew that it would really give a big boost to the battery to be used. Sorry, but when the Schizophrenia network was created, bringing Prescient and Pronet together, these two networks had to go through their own harmonization of the measures. And again, researchers took a long time to decide on the measures, and as time was going, they were using less and less of the harmonized measures. And this is the main limitation that we found. Every researcher has their favorite measures, and it's really, really difficult to come to consensus when it comes to choosing measures. So we thought, okay, if we want to convince people that the harmonized battery is good, it's gonna work, it should have been used in the Schizophrenia consortium, then we need to demonstrate that the protocol is feasible and acceptable by research participants. So that's what we did. We tested feasibility in a study that we called Harmonize. So that's the second part of the project that I'm going to present now. So the aim of this second part, or the Harmonize project, was to test feasibility as assessed by recruitment rate, missing data, or study withdrawals, and to test acceptability as subjectively assessed by research participants. So these results were published in 2022. So we did a bit faster with that study, which was good. Also, because if you notice, between 2020 and 2022, we were in lockdowns more or less all the time due to a certain pandemic that we went through. So Sarah, who was the first author on this paper, she's a research assistant, and she's done an amazing job recruiting participants through the pandemic and collecting all this data as well. So what had to happen is that she would recruit participants while we were in lockdown, and she could go through the clinical assessment online with them, and also she could send the clinical the self-reports to them via a link. But then she had to call them several months later to conduct the assessments that had to be done in person. And so the other strength of this second part of the project is that Somaira, who's the second author here, she's a youth investigator. So we had a young person involved in this project from the start, which was great. And it really highlights how it was a limitation of the first part of the project. We did not have a young person involved as an investigator or as a panelist in the 4 panels that we had to determine the measures. So that was a huge limitation of the first part of the project. So what we did here is we wanted to test the whole battery in participants to see what they think about it, and to demonstrate, as I said before, feasibility and acceptability. So in practice, researchers would not only get a snapshot of the clinical presentation of people through self-reports, they would try to determine some sort of diagnosis, and we went with the mini because it's a bit faster. And then we use the self-reports as I presented before, only the primary set of measures, and we did the neurocognitive assessment as well. Now with the MRI and blood test, because with this study, we were never going to analyze the actual data that would come out at the end of the study, because we didn't have any neurobiological hypothesis there. So the ethics committee thought that it was not ethical to put young people through a real MRI and a real blood test. So we went with mock tests. So with the mock MRI, it's very similar to a real MRI. People are prepped and then they're rolled into the machine and they stay there for 10-15 minutes and they get to enjoy the noise and all the rest, but there's no actual, the magnet is not on. As for the mock blood test, it was a bit more difficult. At that age, young people often have never had a blood test, so they don't really know what it feels like and all the rest. So we showed them a needle, we explained the procedure, we showed them a video, and we really tried to make them understand what it might look and feel like. And then after each of the set of assessments, we sent surveys to the young participants to get an idea of how they found their participation in each of these set of measures. So these surveys were used to collect written information, but we know that some people don't like to write, they're not good with their written words, and so we decided to give them the option to also have an opportunity to speak with us, to talk with us about their experience in the project. So we ran a few focus groups where we invited 3 or 4 people each time. So we screened 48 people. 42 of them were eligible to participate in the project. 28 of them were approached to participate in the project, and 25 responded. A few of them declined participation in the study. A few of them we tried to organize an appointment, but that didn't happen. And one of them was interested, but at the time when we got to them, we had reached our target of 18 participants. So the people that we recruited were from 4 of the specialist clinics at Origin. So the PACE clinic is where we see young people who are at elevated risk of developing psychosis, so the clinical high-risk young people. The EPIC clinic is where we see young people with the first episode of psychosis. HYPE is where we see young people with borderline personality disorder. And then the youth mood clinic, we recruited young people with major depressive disorder from there. So we tried to have diversity in the people we recruited to make sure that it reflects the population that we see at Origin. So in terms of feasibility, we looked at recruitment rate. We recruited 18 of the 25 people that we tried to contact. So anything under than 70% is considered low recruitment rate. But if you remember, another young person had said yes, but we couldn't include them because we had reached our target. So if we had included them, we would be at 68%, and so getting closer to that 70. There was a little bit of missing data in the self-reports, but not too much. So 2 people did not complete them, but they did a little bit of them. So that was not, missing data wasn't too much of a concern. And with regard to study withdrawal, 4 people did not complete the study. So it's a 22% attrition rate. Now we need to remember that this study was never meant to be a follow-up study. It was meant to be a cross-sectional study, sorry. This attrition rate here can be blamed on COVID. It should be 0 because if we were not in lockdowns, people would have been seen within 1 or 2 days to complete all the assessments. With regard to acceptability, so these are the results from the surveys. So the surveys were in 2 sections. There were agreements to statement that we presented to the participants, and there were also open questions. So these are the results of the agreement section. So everything that's on the left of the 0% line is a disagreement with the statement, and everything that's on the right of that 0% line is an agreement with the statement. So the way the survey was built is that the first 3 statements were built in a positive way, while the other 5 were constructed negatively. So the results we have here are about measures of the clinical presentation. So on the left-hand side is the clinical interview, the mini that Sarah did with the participants, and then the self-report surveys were done via a link that was sent to the young people. So most people agreed that the clinical interview was interesting, a bit more not so sure for the self-reports, but everyone felt safe, and they would actually do it again. Most of them would do it again if they were given the opportunity. People didn't think either of the measures were stressful. They, however, thought that the self-reports probably had too many questions and were on the boring side. But the time commitment was not difficult to manage, and it did not interfere with their life. So these are the results for the neurocognition and mock MRI. Quite clearly, agreements to the positive statements and disagreement with the negative statement. So young people didn't mind doing these measures, and similar results for the mock blood test. So I ran through these results, but I have a summary slide here. So participants felt safe while completing each of the assessments. The clinical interview, neurocognitive battery, and MRI were perceived as relatively more interesting than the self-reports and blood test. Yes, self-reports were perceived as too long and boring, and the blood tests looked a bit scary for some of the participants. Most participants stated they would participate in this study again if they were given the opportunity. And I think this is a great result from this project, because the measures that we use are the measures that are typically used in our mental health research, or if they're not exactly the same, they're very similar. So this result is translatable to other studies. When young people decide, they agree to participate in research, they're usually happy with their experience. They do it again, and that's great. It means that they have a good experience with us. And they all agreed that time commitment was not an issue for them. So we collected a wealth of subjective information from the participants through the open fields on the surveys, and also during the focus group. Yeah. Sorry, I lost my train of thought. Yeah, so I will show you some of the verbal or written feedback that we got from research participants. So these first feedback here are about the clinical interview. So someone suggested to conduct the interview in person to avoid technical issues, but someone also suggested that it's nice to be in the safety of our own home during something unfamiliar like this. Regarding the self-reports, someone said, I would do it faster in person. I might lose track if I need to do it by myself. But someone else also said, I would like to do it at home in my own pace, so I can take a break. I would not like to sit with the researcher and feel forced to do it. That would induce stress. So what we hear from these feedback is it's so important to give options to research participants. While someone might want to do everything from home, someone else will just be more efficient and feel safer to do it at the research center. So it's really important to check in with the research participants and see what they prefer. Participants suggested to have fewer questions, less repetitive. Research participants have told this so many times, not only in the Harmonize project, they've told us in every single research participation survey that we've used at Origin. But remember how every researcher has their favorite measure, and that measure really needs to make its way to the research project. We need to be mindful of that. We can't just keep adding and adding measures and measures and measures. Participants don't like it, they get bored, and it leads to them just filling out self-reports without even reading the questions. So we're losing in data quality. We really need to get better at reducing the number of questions that we make our research participants go through. And the other thing that I wanted to point out here is that our interview went for about the average duration for the interview was about 65 minutes, and the average duration for the self-reports was 32 minutes. And this is actually quite short compared to many of the studies that we conduct in youth mental health. Some feedback following the neurocognitive assessments was to get the results from the neurals and also a report at the end of the study. I would like to know the expected outcome and results. So as researchers and clinicians, we know that most of the time, these neurocognitive assessments that we use in research, the individual results don't really mean anything unless they're put together in a group average. But what young people have told us is it doesn't mind. They would like to see some sort of report. And it's the same with the MRI. If we can print a picture of their brain or something, they like that. And it gives them something to bring back home. So we would just need to explain that to young people. You know, these results are your results. They don't mean anything, but here they are. Sorry. And so about the MRI, people said that the movie blocks most sound from the machine and it was a good distraction. Someone else said, I felt comfortable and safe throughout. So I think these results are quite interesting because they suggest that MRI may be more enjoyable and interesting than lengthy interviews and repetitive tasks. This is an important consideration because researchers and clinicians often think that MRIs are too stressful and not well accepted by participants, but our results show that it's not always the case. Some young people find it quite interesting and they don't mind them at all. when we asked about the benefits of participating in the project as a whole, young people said partaking and assisting in the advancement of mental health care. They did that to help people. It's a contribution to science and discovery, and the reimbursement, of course, which is, I think, fair enough. So my conclusions to the whole project was that based on our observations, it appears that the protocol is feasible and generally well accepted by participants. The withdrawal rate and missing data were minimal, and that withdrawal rate is 100% blamed on COVID. The majority of subjective feedback from participants was quite positive. Most participants reported it wasn't difficult to commit to the study and to complete the assessment, and they would do it again if they were given the opportunity. So it is likely that the harmonized protocol would be accepted by young people in broader youth mental health research settings. But remember how researchers have their favorite measures, and so we realized that without funding to support the implementation of the harmonized protocol, it's very hard to get researchers on board. So I would like to conclude by saying that even if this project has not been complete success in the sense that the harmonized protocol is probably not used as widely as we would like it to be, we have found other ways to improve our data sharing capabilities at Origin, and I'll keep that for another presentation. Thank you. Merci beaucoup.
Thank you so much, Suzie, and thank you particularly for joining as you drink your first cup of coffee in the morning to do this presentation. It's much
I've woken up
appreciated.
now. It's almost 7. I'm good.
It's much appreciated. I just want to remind folks that you can add your questions to the chat if you have questions, or you can use the Q&A option. You can also raise your hand if you want to ask your question. I can click unmute. So please go ahead. And I have one question first to start off, which is, I know that you mentioned ethical considerations in large data sets, and well, you mentioned that, and I know that you mentioned that compatibility was your focus, but I was also wondering if you came across and navigated some of the conversations around ethical challenges in harmonizing data around, particularly in terms of like consent or data privacy, and what that might have like looked like if you came across that.
Yes, there is actually, it's very actual. In Australia, we have a working group that is trying to standardize the participant information and consent form across the country. So it's a huge project. And as part of that project, we talk a lot about data sharing because it is in the consent form that participants will agree or not to their data to be used in future research projects. So it's a very difficult question with regard to ethical considerations because the members of the ethics committees are human people, and so they follow, you know, guidelines and the national statement on conduct of research and all the rest. But at the end of the day, they also have their own opinion as to what should happen with data. So there's a lot of work that's been done in educating people as to why data sharing is a good thing, and also educating researchers on how to make sure that privacy is respected. Because once privacy is respected, there isn't many reasons why data sharing shouldn't happen. So it's about education.
Thank you so much. We have another question in the chat, which is, as you said, many folks have their favorite measures, which is a challenge we often face. What recommendations or insights do you have for building consensus around harmonizing measures in an initiative like this?
I'm not sure that my experience is the best to share because it took us an extremely long time to reach consensus. And I was also part in the AMP schizophrenia process of them reaching consensus between the two networks. And that also took over a year. So I don't think I have an answer to that. It's really hard to convince researchers that that measure that you really like, we might not need it for that project. And yeah, it's really about discussion. But I must say, what was missing in our panels was research participants, young people. They were not there. I think we need to listen to them a little bit more. And if they tell us not that measure has nothing to do here, we need to listen to that a bit more.
Thank you. I think that still answers. It's still a bit of a struggle, as you mentioned in your presentation, to figure that out. And
Yeah.
um, I'm wondering if anyone has any other questions they'd like to ask. Reminder, you can raise your hand and I can unmute you.
One thing I didn't mention is that the way we suggested researchers to use the harmonized protocol is to make sure that they do use the self-reports, because this is where we want to get the clinical snapshot of the research participants. But then the other modules, they could be added to the projects if needed. They didn't have to use them if they didn't want to collect an MRI. They didn't have to. Yeah.
We have another question. Are you reading the one in the chat for me?
Okay, what are your thoughts about balancing harmonization through a common protocol versus customization to ensure that methods address the specific questions researchers may be trying to add? Can you please explain what you mean by customization?
I'm going to give Ian the ability to chat. So allow to talk. You should have the ability to unmute yourself now, Ian, and ask your question.
Thanks, Ian.
Thank you. I was just thinking about this as you were talking. I was thinking about how, sometimes we want to make sure that we have these like really big data sets so we can have confidence in the answers we're thinking we're finding, and having harmonized protocols is so useful for that. But I'm also thinking that, sometimes we have kind of, as you said, researchers have their favorite measures, which may or may not help. And sometimes those measures can actually be useful for answering really specific questions but also make it hard to harmonize. I'm curious as to like what your thoughts are about balancing those two challenges.
Yeah, well, again, if I come back to our harmonized protocol, the idea with that was to use that core self-report measures to get the clinical presentation. And then researchers say, for example, if you're eating disorder researcher and your favorite measure wasn't in there, of course, you can add that. But we always go back to don't add too many. Make sure that you can answer your main research outcomes. You don't have to have 20 exploratory questions. So it always goes back to, yes, add your measures that you need, but limit them and make sure that you have research participants in the room to tell you when to stop.
Thank you so much. And thank you, Ian, for coming on to ask your question. I want to give the final chance before I let Dr. Lavoie go and enjoy the rest of the morning in Australia. Okay, I'm going to say thank you so much for joining us. And again, it's been a pleasure to get to connect with you and to have you on the series. We really appreciate it. And for folks, I'll add it in the chat right now just so you have the link. But if you want to see the other webinars, you can go visit the YouTube, and I will edit and upload this webinar very soon as well. So you'll be able to watch this again and share with others. Thank you to everyone for coming and joining and for asking questions. We really appreciate it. And we'll see you again soon. Enjoy.
Thanks so
Thank
much,
you.
Alyssa. Thanks, everyone. Thanks for having me.
Bye.
Bye. Bye-bye.